Hello and welcome. I'm your host, Neil Howard. Glad that you could return for another segment of Health Professional Radio. We're going to be speaking with Dr. Nicholas Kassebaum. He's joining us here as Adjunct Associate Professor in Health Metric Sciences at the Institute for Health Metrics and Evaluation. He's going to talk about the findings from a new study conducted in conjunction with SmileTrain, looking at the impact of orofacial clefts and undernutrition. Welcome to Health Professional Radio, Dr. Nicholas Kassebaum.
Thank you for having me. It's a pleasure to be here.
Good. Well, what is your area of expertise, and where is it that you're practicing?
So my area of expertise is twofold. I am a clinician. I work as a pediatric anesthesiologist. I've split my time between Seattle Children's Hospital and Harborview Medical Center, both in Seattle. And I also do a lot of health statistics research. For the last 10 years, I've been working with the Institute for Health Metrics and Evaluation on a project called the Global Burden of Disease, where we analyze and try to understand all of the different reasons for health loss due to diseases, injuries, and risk factors in different countries throughout the world.
Well, when it comes to orofacial clefts, what causes them, and what is it about clefts that make you concerned with undernutrition?
Sure. Clefts are actually They're one of those conditions that we would categorize in a broad category called birth defects. And what happens is that during fetal development, a certain part of the mouth and or lip doesn't fuse properly in the midline. So you can actually have a gap in the front of the lip, or you can have a gap in the palate, which is the roof of the mouth. And there is some assumptions that people have that those are cosmetic issues, but what we also know is that newborns need to be able to suck and suckle in order to breastfeed and get adequate nutrition. And so it also causes issues with that. In addition, those children who have clefts, for a number of different reasons, are also much more prone to aspiration, so they might inhale during their attempts to eat and develop pneumonia from that, or other respiratory infections and other infections. And all of these really conceptually would put a child with a cleft at pretty high risk for developing malnutrition.
Are there different levels? I mean, are there like a small cleft or a major cleft that requires surgery immediately? Or are there clefts that a person can just go through life and it is actually a cosmetic issue?
There are certainly different severities of cleft. So the worst cases where the lips are quite far, the edges of the lip are quite far apart, and there's a large gap across the entire palate, the entire roof of the mouth going to the back. And that can really hinder a baby with severe cleft's ability to feed, and can take many, many different surgeries and operations in order to correct. And there can be very small gaps of just an isolated small cleft lip may only cause a small decrement in the baby's ability to feed. Mm-hmm. And there are some people who live much of their childhood and into adult life and found to just have a tiny hole in the roof of their mouth when they're adults. And that's technically a cleft, but maybe for that person wouldn't cause a problem. But we do know that a large proportion of them do require surgery to prepare. The only cure is surgery, and a very large proportion of them will require an operation to treat it.
Now, as far as this new study is concerned, can you give us an overview of the study and tell us what a couple, maybe 2 or 3 of the key findings are?
Sure. We at IHME, the Institute for Health Metrics and Evaluation, as I mentioned earlier, do a lot of work to try to understand the comparative levels of different diseases and risk factors throughout the world. So my team, 2 of the items we look at is what is the epidemiology, so like the prevalence and incidence, how many people are likely living with clefts throughout the world. And to do that, we have a lot of data on cleft itself, but maybe not a whole lot of contextual information about the other things that happen with those people who have cleft. We also have a lot of data and a lot of understanding about rates of malnutrition, which is quantified of like weight for age growth curves is a really common one. but we don't necessarily have a lot of information on what are the other problems that kids with malnutrition have. Mm-hmm. So when we started talking with Smile Train, what they have collected over the last couple decades through their massive international organization is when kids are coming for cleft repair surgery, they actually measure the height and weight and age, of course, of children. And so we were able to come together and using the hundreds of thousands of kids who came to surgery with Smile Train, see what is the rate of this malnutrition, type of malnutrition called underweight. What is the rate of underweight in kids with cleft, and how does that compare to the rate of underweight in the general population? And it's a way of getting at what is the excess risk of kids with cleft to actually become malnourished. And there's a way to triangulate between and approximate the overall burden and impact of malnutrition in kids with cleft.
Can you share with us which places perhaps had the highest cleft prevalence rates and what's being done to address the problem and treat these kids? And then give us a website where we can learn more.
Certainly. The places with the highest cleft prevalence rate are mostly in North Africa and the Middle East, extending into South Asia and Southeast Asia. The reasons for that are not entirely clear because there's lots of different possible reasons one can develop cleft. The rates of malnutrition are highest in South Asia and in many parts of sub-Saharan Africa. When we combine those two together and see what the rates of malnutrition in cleft, the first thing that comes out is those who have cleft are much more likely to be underweight than the general population in every circumstance. But when we combine those together, big hotspots that come out are the countries of sub-Saharan Africa that border the Sahel, so places like Mali, Chad, Nigeria, Niger, Somalia, and a lot of the countries of South Asia because of their really large populations and big issue with malnutrition, so like Pakistan, Afghanistan, Bangladesh, and India. The things that are being done to address the problem, I think Smile Train is a real global leader in this area where they work with local partners to help develop capacity for surgical treatment of clefts, for prehabilitation, so identifying kids who are at risk of malnutrition and helping maintain or recover weight gain, which does them well overall and portends well for post-operative recovery. And really trying to raise awareness for early detection and early identification of clefts so that those kids who have them can be referred to both supportive treatment and curative treatment. The biggest website to go to, smiletrain.org, is a great resource for the overall work that Smile Train does, and then IHME can be accessed through healthdata.org. To see both the results of this study and some of the other work that we do.
Dr. Kassebaum, thank you for joining us here on Health Professional Radio. It's been a pleasure speaking with you.
Thank you. Thank you very much. Have a good evening.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Nicholas Kassebaum. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at Anchor, Spotify, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.